Hello everyone. Good afternoon. Welcome one and all. Uh, Today we have a wonderful opportunity to discuss about telepsychiatry, the best practices, guidelines, and potential solutions during COVID-19 and the time beyond. So in today's webinar, we have two eminent speakers who have immense amount of experience in the field of telehealth and telepsychiatry. To begin with, I have with me Dr. Suresh Bada. He has done his MD and DNB Psychiatry from Nimans, Bangalore, post-graduation, PGDME, and PhD in Law from National Law School, India, University, Bangalore. He is the current professor and head of the Telemedicine Center, head of Forensic Psychiatry, and consultant community psychiatry. He is also a president of Telemedicine Society of India, Karnataka branch. Currently, he is affiliated to the Department of Psychiatry in Nimans, Bangalore. He is also a visiting faculty at the National Law School, Bangalore, State Human Rights Commission, Karnataka Judicial Academy, Bangalore. Dr. Suresh has around 232 published scientific articles in index journals, and he is also an editor of 3 books. He's been awarded with Professor Raghuram's Distinguished Young Teacher Award and Dr. C.V. Raman Young Scientist Award by the Government of Karnataka. He has held member positions in the committees like Central Rules Drafting Committee for the Mental Health Care Act in 2017, and he was also part of the Task Force for Mental Health Care in the primary health centers under the guidance of Mental Health and Family Welfare, New Delhi. We welcome you, sir, again. Thank you very much. We have one more distinguished speaker, Dr. Dave Musich. He is a psychiatrist located in Denmark. He has a special interest in the use of technology of mental health care, what we call e-mental health. Dr. Dev has established the Little Prince Psychiatric Center in Copenhagen, where he developed telepsychiatry since 2000. In 2011, Dr. Dev has also launched a tele-mental health section within the European Psychiatric Association. In 2015, he has reactivated the section on informatics within the World Psychiatric Association, and he is also an active board member. Dr. Dev is also editor-in-chief on Edorium Journal of Psychiatry. He has published a number of articles related to the field of telepsychiatry, and the scientific articles about the first international telepsychiatry service in the world and the cross-cultural telepsychiatry service in the world, established in 2004. To his credit, he also has published a book, E-Mental Health, in 2016. Currently, Dr. Dev coordinates expert group on e-mental health within the World Psychiatric Association, aimed to propose a plan of action related to the World Psychiatric Association's response to the COVID-19 pandemic. The network of experts is supposed to help the World Psychiatric Association and its member societies in dealing with mental health consequences of the COVID-19 pandemic. To just open the conversation, telepsychiatry has been seen at a growing rate, almost amounting to 150% year on year. This is one of the top 5 most consulted specialties in the last 3 years. The telepsychiatry has witnessed an enormous growth of around 240% since March 1st. The increase in queries are largely growing even in the non-metro cities, almost amounting to 130% year on year. There is about 74% consultations predominantly coming from men during this period. So the Practo Insights also provides certain demographics, like the top queries have been anxiety, depression, stress management, panic attacks. Although the data distribution is largely skewed towards men coming up with queries and more with the metro than the non-metro cities, but all the sectors have been catching up, especially in the current times. With this brief introduction, I would hand it over to Dr. Suresh to start his presentation. Thank you. Welcome again, sir.
Thank you, Venkatesh. Now we will directly enter into the presentation. Yeah, we will directly enter into the presentation. So before I start my presentation, I would like to have a disclaimer. Today, what we are going to discuss is basically more of academic in nature. If you would like to have any legal opinion, please do contact an advocate. At the same time, I also request the participants from India to look into the telemedicine practice guideline, which was released by Ministry of Health and Family Welfare on March 25th. So That's the basic guideline or the framework on which this today's presentation moves forward. So also declaring about the conflict of interest. My conflict of interest is none. I'm not being paid from any pharmaceutical company or from the corporation or from the Practo. So I'm here for telepsychiatry promotion. So this is the telepsychiatry operational guidelines, which was released recently. This is a work done by Indian Psychiatric Society, Telemedicine Society of India, and NIMANS. Basically, NIMANS is National Institute of Mental Health and Neurosciences. This operational guidelines was released. It's a combined activity, not one institute. And coming, what was the need of this guideline when we have already had a telemedicine guideline? Of course, we have one is telemedicine practice guideline notification occurred. At the same time, in the background, we also have a Mental Health Care Act. So that Mental Health Care Act talks about the rights of a person with mental illness. So now when we are using telemedicine practice guidelines, and you have to uphold the rights of the persons with mental illness, we cannot take it granted. So we have to combine these two, and then we have to come up with the guideline, which made us to come up with the telepsychiatry operational guidelines. So this is not a standalone document. You cannot say that I'll be taking only telemedicine practice guideline or only telepsychiatry operational guidelines. No, this is a guideline which, after Mental Health Care Act and also MCI, Medical Council of India ethics, and then the telemedicine guidelines, after that this comes. Along with this, you need to follow any clinical standards, protocol, policies, procedures, all those you need to follow. So that's very essential. So please do not take this as a standalone document. Moving to this, operational guidelines has various chapters, and also 6 important appendix have been there. So it is available freely online, and if required, we will be able to happy to share this. It's a free of cost. So we will start with the scenarios rather than directly going into the guideline, which will be very difficult to understand the law. The law needs to be understood in the context of a cases. So the best way to understand is through scenarios. So we will start with this Mr. X. Please do remember this Mr. X continues through my presentation. So Mr. X is a 38-year-old patient, communicates to you for the first time with history of feeling breathlessness, panic, anxiousness, and decreased sleep through text or by an email. What should I do? So you are a psychiatrist, he has contacted you. So this is a first consult as per our telemedicine practice guideline. So the first consult means if the person is contacting you for the first time, or else he is your old patient, but he has not contacted you for past 6 months, then also he will be your first consult. That means he has seen you 1 year back and now he is consulting. It will be still a first consult. And also he has contacted you 1 month back, but now he is contacting you for some other reason. For example, he has contacted you for the diagnosis of schizophrenia, but now today he is contacting you for seizures. He has developed generalized tonic-clonic seizures. Now also it will be considered as first consult, though he has consulted you 2 months back, because it's a different health condition. So this is how he does it. He will contact you either by text, audio, video. Once he contacts you, it is called as implied consent. So this is as per the telemedicine practice guideline. But however, at the same time, now we bring in something called as telepsychiatry operational guideline, where we send the patient some of the, like he has contacted you, you can send some documents to fill or ask him to send the ID or past treatment, past investigation, where is the location of the patient. Those are the things you are going to ask him. And also you look at the patient identification, and then you will start the telepsychiatry consultation. During that time, you'll quickly assess for any emergency. If there is no emergency, you will continue with the consultation. If there is an emergency, as per the telemedicine guidelines, you have to refer him to the in-person consultation after giving him first aid advice. So this is the document. When he contacts you, it's an optional, it's not mandatory. You can send him. The reason being is, see, this document has what we call it as the minimum demographic details. What are his chief complaints? See, there is very essential things we are adding here, because I'm from a legal background, though I'm a doctor, I've done my PhD in law. See, the question number 8 and 9, we are looking at the legal issue. Let him declare that he has any legal conflict or legal issues. So he will fill this. It's an optional. If he is educated, he will fill and he will send it to you. So this becomes your medical document. And at the end is your notes. So you need not worry about what should I write, what should I keep the EHR. So, but this is an optional one. I'm not telling it is mandatory. Okay, so this is an optional. You can send it to him. He will fill it, and so this becomes a medical record. Along with this, when he's sending, he will sign it, take a photograph, and send it. This is a consent form which has a detailed information. What are his rights? What are the rights of the psychiatrist? And what does Mental Health Care Act says? Where to access telemedicine practice guideline or telepsychiatry operational guidelines? Those are all mentioned here, so that he will give the signature and send it. So this becomes a medical document. This is again as per the Mental Health Care Act. You have to keep some of the basic medical record. For that reason, it is very essential. So these are the do's and don'ts we have clearly mentioned. I would not go into the details. So this is available in the appendix. Please do go. This presentation is more of giving you the bird view of the whole telepsychiatry operational guidelines. So once he has sent you the documents, either after doing the assessment or during the first consultation, either you will do health education, counseling, and now you are authorized to give medication list to who is over-the-counter medication. This is as per the telemedicine practice guidelines. If you are doing video consultation, list A medication you can prescribe. So we'll come to this, what is this list A, in a short while. So next, the scenario 2, the same Mr. X patient, you have prescribed some medicine. It was a video consultation. Now, Mr. X patient calls at an odd time seeking telemedicine consultation. Imagine your number is available on the internet, your name he knows, he calls you. What should I do? It's in the midnight. So odd hour consultation. The doctor can choose either to attend the call or not to attend the call. This is as per the telemedicine practice guideline. The doctor can also choose not to provide telemedicine consultation, of course, after the duty hours. It is the professional judgment and discretion of the doctor to provide emergency care or odd hour care. So this has been very beautifully spelled out in our telemedicine practice guideline released by the Ministry of Health and Family Welfare. So you have decided to give or not to give, it is left to you now because it is an odd hour consultation. Coming to scenario 3, what to do when Mr. X, the same person, Mr. X, who is having depression, 38, calls for an emergency consultation now. It's in the daytime and he knows your number. He called you for a emergency telemedicine consultation or telepsychiatry consultation. What should I do? So if it is an emergency situation, now you will move to telemedicine practice guideline. Here, you are supposed to advise him for in-person consultation because in emergency situation, he may be somewhere, you may not be able to do anything much. Okay, it's doctor to patient I'm talking about. If the patient is with another doctor, the things slightly change. Okay, here it is an emergency situation. The patient is alone. Then you will do first aid advice, counseling, and you will facilitate the referral so that he goes to the doctor at the earliest. So this is the emergency situation where it's very, very essential that you will not engage him for longer duration. So the doctor should record his statement, what he has told, and also what advice is given, and also the referral, what he has done. So please do remember the rule of thumb in-person consultation is essential for emergency care. You will not, what we call it as, engage the patient for longer duration. Coming to the scenario 4, in case if there is a problem with the internet connectivity, you are doing some consultation, first consultation, or else the emergency consultation, what should I do? Either the internet connection may be at the psychiatrist side or the patient side, or maybe the server is down. In Koramangala, Bangalore, it may be down. So both the side internet is good. So there is a scenario this may happen. If it is in the early part of the session, stop the session. You may have to re-give the, what we call it as the consultation, or else at the end of the consultation, you have already finished around 8 to 10 minutes. So its last part is that you can call up, phone call, and complete the consultation. So it should be planned before in hand how many minutes the consultation lasts. So that's the very essential point of the telemedicine. So at the end of the first consultation, it would be a good idea to send the feedback form. So send him, let him fill and send it back, because you'll come to know because you don't know the patient side, what was the internet connectivity, what was the video quality, audio quality, communication. Did he understand the prescription if you had sent? Is there anything he has a question? If he has made any comments, please do contact him back and ask him, how can we help? There was the rating was less. Is there anything which requires to be addressed? So that, or any suggestion. So those things will allow you to settle the issue before it gets to the higher level. Scenario 5, same. Now you have given some investigation. The prescription of investigation, will it be honored or not? Maybe it may be CT scan, it may be thyroid function test, or any other biochemical investigation. Of course, it will be honored as per the telemedicine guidelines. So they are now honoring the investigations given, and also the e-prescription. Earlier, there was a problem because of certain issues, but now they are honoring in almost all parts of the India. And at the same time, you need, when you are giving a prescription, please do follow clinical practice guideline. The clinical practice guideline, which will, see, this is the commonest question many of our psychiatrists ask. Should I follow American? Should I follow European, Canadian, or should we Indian? I would rather say you follow Indian law, better to follow Indian clinical practice guideline. Because if you look at the clinical practice guidelines of seizures, there still we have phenobarbital, phenytoin. But if you look at the American, they don't exist. They're the toxic medicines for them. So here it is available. So you need to, and also when we argue in the court of law, if I say I'm using Indian clinical practice guideline, the judge will be very happy to say, okay, you're using Indian, similar to Indian law. Then they will continue with this document as an evidence. Usually that is the way nowadays the consumer court, many of our doctors are sitting there. They know what is the value of the local practice guidelines. Scenario 6, Mr. X sent you all his investigation, general physical examination through messaging or email platform. He's requesting for telemedicine consultation. What should I do? Okay, so is it a follow-up or a new consult? It is still a first consult, because if he's contacting you after a long time, that is more than 6 months. So it will be follow-up if it is within the past 6 months only. He has seen you in person, and within 6 months he has seen you. He is going to contact you. It is follow-up. Otherwise, it will be first consult if it is more than 6 months. Scenario 7. When do we call Mr. X is on follow-up telemedicine consultation or follow-up telepsychiatry consultation? So follow-up telepsychiatry consultation will be in the past 6 months he has met you in person. That is very, very essential. So he has met you in your chamber, in person, face-to-face consultation is there, and he is now asking you telemedicine consultation in the 6 months. Then it becomes a follow-up telemedicine consultation. And it should not be for the other health condition. It should be for the same health condition. So that is very essential. At the same time, by chance, you are a very busy practitioner and you don't remember that you have seen him 4 months back. Then also it will not be considered as follow-up. It will be called as a first consult, because that kind of freedom has been given in the telemedicine guidelines, which was released by Ministry of Health and Family Welfare. So follow-up consultation, it should be 6 months. In-person consultation, same health condition, and you should remember, or you have a EHR. So that's the way it is. If you don't have, need not worry. You can't recall, you can say it's a first consult. So this is how it goes. Patient contacts you, it becomes implied consent. And then there is, though it is implied consent, usually we send again a pro forma to them so that he fills and also says that there is no legal issue, or he requires a certificate, because many a time patients see you and suddenly after 2 weeks they will say, I want a certificate. So these are the issues. Many a time they call us and ask, so what should I do? So once he fills the pro forma and sends you, patient identification is done, quickly assess for the emergency. If there is no emergency, we'll continue the consultation. If there is an emergency, we'll follow the telemedicine guidelines, asking him for in-person consultation. This is the way the consultation pro forma goes. And also here we have added something called as, where is his location now? Because the telemedicine practice guideline clearly says that the jurisdiction of practice should be within India. Suppose the patient, you have seen him, is from Bangalore and he goes to maybe Germany and he's consulting from there. So you want to know where he is initiating the consultation. So for that, you need to have where the person is staying, so that there is a clear mark, and also when was the last in-person consultation. All those things, is there is any family discord, marital discord, legal issues, let him declare to some extent, so that it's basically safe practice. That's what I'm trying to take. It's again optional, it's not a mandatory. So again, you will do health counseling after completing the assessment, or else refill of the old medication. And now you have an option to choose medication list. This is a new complaint is arising, then it will be a new consult. Coming to the scenario, how often a patient requires to come for in-person consultation for telefollow-up? For telefollow-up, he has to meet you at least once in 6 months. This has been deliberately kept, because when the Telemedicine Society of India and even MCI, when they were discussing about this, one of the things which we actually asked for is at least once in 6 months they have to meet so that we can do general physical examination, because many of us are worried. So 6 months once we need to have, if serum lithium may be there, it may be serum valproate or LFT, biochemical investigation, thyroid function test. Invariably 6 months once is our general psychiatric guideline. So for that reason, 6 months once he has to meet you, then only he can be given telefollow-up. And also the list B medication can be given. Moving to the same person, Mr. X. Now, after 2 years, he is contacting. After 2 years, he has not contacted you. Mr. X is refusing to take medicine and is refusing to come and meet you. And the family members are requesting for telemedicine consultation. What should I do? Can a family member can contact and a proxy telepsychiatry consultation can be given? Yes, of course, telemedicine practice guideline allows for a family member to initiate a telemedicine consultation, but you have to be very careful. There is a Mental Health Care Act available. So now you have to bring in Mental Health Care Act. It should be a nominated representative. One possibility, if there is no NR, the family members can are authorized to contact if he is a child. The child, again, as per the telemedicine practice guideline, it is 16 years, not 18 years. Why 16? I don't know. They considered as 16 is the best. And before they initiate, an explicit consent is required, that explicit consent is not there in telemedicine practice guideline, but psychiatry operational guidelines, we have come up with the, what we call it as, this is the formal authorization letter. If the patient doesn't want to come, but he is able to sign and send it, it's well and good. So this, he will send it across to you. So caregiver, who is the caregiver? Caregiver may be the family member or NR. So there are two scenarios here. The patient and the caregiver are available. In the another scenario, the patient is not there, only caregiver is there. So when the patient and the caregiver are coming together for a telemedicine consultation, so you can ask the patient, are you comfortable with the caregiver sitting next to you or not? And then you will head with the consultation, taking the consent of the patient. And if the patient's capacity is not there and the family member, caregiver, you are able to identify, you can continue the consultation. Suppose if there is no patient, what should I do? Then you will ask for a formal authorization letter. If there is no formal authorization letter, you will not continue. So again, with this, there is a simple algorithm is there that is there available in the telepsychiatry operational guidelines. So if it is the patient has come recently 1 or 2 months back and is a dementia patient, very old, you are able to recognize the family member, you can go ahead with the consultation. Because the dementia severely ill and he is not in a position to give even a formal authorization letter. So in such case of geriatric cases, you are allowed to do telepsychiatry practice. So coming to scenario 10, initiation of telepsychiatry consultation by a family member. This is how we are going to do. So initiation of telepsychiatry consultation by a family member with the patient. This I have told you, if he's an adult patient, if it's a children less than 16, the child is not required. You will do with the teleconsultation with the family members. If it is an adult patient, you will ask the adult patient whether he is fine. You'll check for the capacity and you will ask whether the requirement of a family member is there or not, is comfortable or not, and you will do with the consultation. If there is no capacity, please do understand, if there is no capacity, so then if it is a first consult, you will not continue. You will ask them for in-person consultation. You will do assessment and you will say, before you issue any prescription, you'll say, you have to come for in-person consultation because there may be many scenarios may happen. It's a first consultation and the patient is coming and there is very difficulty to continue. It will be asked for in-person. In this, any process, you find there is any foul play, please ask for in-person consultation. Don't be shying away. No, I have been forced to give a prescription. Don't do that, because telemedicine practice guideline says that before you issue a prescription, diagnosis is very, very essential. Without even a provisional diagnosis, if you issue a medication or a prescription, it is amounting to misconduct as per the telemedicine practice guideline. So you have to be clear about this. So initiation of a telepsychiatry consultation by a family member without a patient. If there is no patient, what should I do? So this is the simplest form. So a family member has contacted you, and if it is a first time, you'll ask for in-person. You will ask for the information. You may educate them about Mental Health Care Act, and you say that you need to come here. You have to bring the patient. No, he is a telefollow-up, the way I said for dementia patient. Check for the ID, look for the authorization letter, but you are able to recognize the family member, you will go ahead with the consultation. No, you find that there is identification is not possible, you ask for in-person consultation. So this is how, with or without patient, with the family member can be done. So this is where a telepsychiatry operational guidelines comes into picture, where telemedicine gives a broad guideline. We have operationalized it in telepsychiatry operational guidelines. So now comes the proxy consultation and proxy prescription. Can I do this? This is one of the questions which is very often asked by our psychiatrist. So please do understand, do not give a prescription to a caregiver in the absence of a patient, unless you can give only if there is a formal authorization letter, proof of ID you are able to establish, relationship you are able to identify, because the patient is brought by the same mother or father every time, and you're able to identify, you can go ahead and give even if there is an authorization letter. So this is a very common practice we see in Bangalore. Like the patient may be in Rajasthan or in Delhi, somewhere they are working. The family members say, please do give the prescription. You can send the prescription. And the patient says, my side internet is not working. So you can go ahead and do the consultation. Coming to scenario 12, Mr. X is refusing to take medication and refusing to come for consultation, even for telemedicine. Family members are requesting for injection now. They say, sir, you had mentioned me, or I have done the internet search, and they say that there is a injection, something called as Risperidone, long acting. Why don't you give that so that we can give an injection? In such scenario, wherever there is an injection is required, as per telemedicine guidelines, in-person consultation is very, very essential. Don't prescribe injection. If you want to prescribe an injection, it has to be for another healthcare provider. It may be another doctor, or else a nurse who has been trained in giving injection and knows the side effect that if anything goes wrong, you will be held responsible. Because the telemedicine practice guideline, the FAQ which was released, they are very clear. Apart from insulin, or if there is no any other mode of giving medication, injection prescription has to be given to another healthcare provider. Coming to this has been clearly told in the telemedicine guideline FAQ that was released by Board of Governors. So please do look into that. So if something goes wrong under vicarious liability, you will be held responsible. So before you prescribe injection, please keep it in mind. Now, there is another issue which has been many of my psychiatrist colleagues are asking, sir, if a rehabilitation center, a social worker is contacting, or else I have a rehabilitation center, I do visit once in a month. But if there is some issue, they want to contact me. Can a healthcare worker from the rehabilitation center can initiate a telepsychiatry consultation? Of course, this is allowed here under telemedicine practice guideline. It is very clear. Healthcare worker can be a nurse, allied health care professionals, or else even a social work who is there can initiate the teleconsultation. But however, the person who is initiating, healthcare worker, should be with the patient, should have examined the patient, should have examined the ID, and then they will take the consent, and then they will contact you, and then you will again verify the ID, and then you will go ahead with complete the consultation, and you can issue the prescription. So this is how you are going to do if the healthcare worker in a community setting from the house, and this becomes very essential, especially Section 94 of Mental Health Care Act. In an emergency situation, the patient is very violent, you have to send an emergency ambulance. If the ambulance goes along with that, there is a nurse in the ambulance. That nurse can do the assessment of capacity, and then they can switch on what we call it as the telemedicine consultation can be started by the mobile phone, and then you can initiate the consultation, which has been clearly depicted in telepsychiatry operational guidelines. Please do go through that. So these ambulance services which have been denied very long can be initiated through this healthcare provider initiating telemedicine consultation. Scenario 14, I'm almost coming to the end of my presentation. With medication part I'll be discussing. Mr. X is admitted in my hospital now since past 1 week. Now I have to go and attend some conference. Should I do telemedicine consultation if the patient is in my hospital and I'm somewhere else? Can I do that? Of course, the telemedicine practice guidelines do not prohibit that. But however, again, if you are doing it, there should be a healthcare provider nurse next to him, and she will initiate the consultation after taking the consent. So this can be done. Or else, if you have a patient in your own hospital and he requires a cardiac consultation, why to send him during this pandemic? You can initiate a telemedicine consultation, asking his consent, take the explicit consent, contact the cardiologist, and the consultation can be completed. So this is the beauty of our telemedicine practice guideline. I have done the review of almost many countries' telemedicine guidelines review, even American telemedicine. This is one of the best. If you ask me, the freedom is amazingly has been given in our Indian telemedicine practice guidelines. Moving to the scenario 15, Mr. X is discharged from my hospital, but requires CBT. Can I do therapy on telemedicine? Of course, it is allowed because online consultation or online therapy is a part of providing care. So you can go ahead with the consultation, but every session, please do understand, every session, please do assess for emergency. That's very essential because there may be some crisis. They may contact you only in crisis for therapy. So that's very essential for that. So that's, again, we have clearly documented that. So please do keep mandatory teletherapy records as per Mental Health Care Act of 2017. This is the record which is there, which is part of Mental Health Act rules. It is there. This is what it dictates under the rules, central rules, and also the state rules has not been notified in many states. But however, a model state rules given by the central government will applicable even if your state has not formed state mental health rules. Please, I'm repeating this. If the state government, like for example, Karnataka state mental health rules have not been notified, but however, central model rules for state is there, that will be applicable now. So you can't say that no, state rules are not formed, I'm not following it. No, that is not applicable. That is not accepted in the court of law. They will say there is a central state model rules. It is available. You can find it online. So this is the consent form for the therapy. Coming to the last part, question and answer session. Many of the questions which I have done, these are the questions commonly asked. Can you please clarify about the medications? The medication list O, A, B. Venkatesh, I'll be finishing in another 5 minutes. List O is over-the-counter medication. List A are relatively safe medicine. List B is basically chronic condition you are giving. Please do understand, don't prescribe list C. I'll come to that now. List O, list A, list B, you know about the telemedicine practice guideline. Now I'll go into these telepsychiatry medications. See, list A, there was two approaches when we discussed with IPS. One was choose all first-line medication, put it under list A. But unfortunately, what happened was, for a schizophrenia, I'm giving an example. Schizophrenia, if it occurs in a child, adult, if it is in a pregnant woman, if it is in a postnatal, geriatric cases, with diabetes, without diabetes, the first line medication changes. So list A goes on changing now. So that became a challenging because just for a schizophrenia, we have to do it for list A and we have to list all diagnoses and then come with first line medication. That became a biggest problem. We tried doing this, but it could not happen. So immediately we thought of then that something clicked. There is something called as essential medicine list as per Mental Health Care Act. Essential medicine list is also there under the Government of India. So immediately we thought, why not go for list essential medicine? When the essential medicine list was brought in, which is available under district mental health program, the government immediately accepted it actually. They said, wonderful, this is a good idea. Essential medicine can be the list A. So these are the essential medicine. Imipramine, though this has its own, what we call it as drawback, but also it was easy to get the policymakers into the discussion. So the list A was easily taken. And also these are the medicines which is available on the telepsychiatry guidelines. I will take questions regarding this. Coming to the list B, which is not there in list A, comes into list B. And we actually, what we did was, if you look at any other antipsychotics, for antipsychotics, any other antidepressant, any new medication comes in will be immediately added to this list. So that's the beauty of what we have planned it. So you look at the end of antipsychotics, we have said that any other antipsychotics, any other anti-craving agents. So please do that. Remember that list C, don't prescribe. Don't prescribe list C. The list C has two things. One is NDPA, the drugs listed under narcotic drugs and psychotropic substance, and drugs and cosmetic act schedule X medicines. Please don't prescribe them. If you prescribe, let me tell you, it will be misconduct and you will be having a problem. The reason being is, I'll give an example. Buprenorphine. Okay, so you can take methyl phenobarbital, or you can take even methamphetamine. The best would be the buprenorphine In Karnataka, we can give for 1 week, 2 week OPD basis. In Punjab, it is not allowed. Imagine if I'm sitting here as a psychiatrist and start prescribing medicine for a Punjab patient, their NDPS state rules prohibits. So you should know the state-wise difference in that. So that becomes a problem. So that is the reason these medicines have been said no, and it can be misused. Please do understand. So it becomes a big problem for the government to manage this or control NDPS medication, because the medicines has to be transmitted from one place to another place and through other maybe various ways. So that becomes a biggest headache. So these are the prohibited medicine. Please do understand benzodiazepine falls under this, but however clonazepam and clobazam has been amended by the Medical Council of India. So this is the letter which is available on 11/4/2020. So clobazam, clonazepam and phenobarbital have been given permission to give in list A, either in the first consult or in the follow-up consult. So format, this is the prescription. I need not go ahead with this. Please do just write the ICD code or DSM-4, because under section 23 of our Mental Health Care Act, it talks about what we call it as the confidentiality, right to confidentiality. So diagnosis better not to make it ICD-10 or DSM-4, EHR, EMR. I will not go into that. This again, we have to have the records as per the Mental Health Care Act. That is the Rule 6.3 Form B. So you have to have these records. You cannot say that it's a telemedicine consultation. I'm not going to keep it. It is OPD basis. It's not allowed under the basic medical records of Mental Health Care Act. Please do keep the records. Don't send it. Keep all the prescription, whatever you are sending, transmitting the prescription, a copy should be with you. So access to basic medical records, how we will do, it's a authorization letter has to be sent. If you're not comfortable, ask him to come in person and ask for the what we call it as show his ID, then only we'll give the records. That's left to you. So what are the medical legal issues? I think I will take questions on medical legal issues rather than discussing that. The last part one, if what to do if there is a conflict with law, and what should I do? Whenever there is a conflict in law with the patient, ask them for in-person consultation. That is a simple rule of thumb. If you have a doubt, ask for admission for observation. So that will be the best way to go ahead, because telemedicine guidelines also allows and telepsychiatry practice guidelines also allows. But if he is your old patient since past 5 years, you're seeing him and you know his diagnosis, you can outrightly give the certificate. It is the professional discretion of the psychiatrist which matters most here. To conclude, this is one of the best guidelines we have in our what we call it as across the world, if you ask me. And this is going to be a game changer, especially telepsychiatry guidelines and also telemedicine guidelines. Many other fraternity medicine, pediatric, they are still debating about list A, list B, but we have already come to know what is list A and list B. So this telepsychiatry operational guidelines would be easy to practice. So if you would like to go through all these my videos, it's available on YouTube. You have to go to youtube.com, see Suresh Bada. It will be available. Even medical legal videos are available. And I'm doing all the legislations related videos. Thank you very much, Dr. Venkatesh and the Practo for giving the time.
Thank you very much, sir. That was a very crisp and precise summed up presentation. He has covered up almost everything. And as he said, he is a doctor and he is a lawman. And I think he will take up the questions related to the legal issues related to telepsychiatry during the Q&A. Now I would request Dr. Deva to take up the platform, and he would be speaking about the global perspectives as well as telepsychiatry is concerned. Thank you very much.
Thank you very much for inviting me to this webinar. I hope that the quality of sound and picture is good. It is. Okay, great. I'm so happy to be here because within the last few weeks, I've been reading telepsychiatry operational guidelines done by colleague Dr. Suresh. During his presentation today, although I have seen one of his webinars from last year, I decided to change my presentation slightly because I got some ideas and maybe some additions that you could be interested in. However, the idea of video meeting in medicine is not new. Some visionaries, they imagined that the radio waves could be used in order to transmit the picture and sound from the patient to the doctor. And it has been first mentioned back in 1924. However, we know that telepsychiatry, interactive video conference in psychiatry, has been in use since 1959. We professionals, we have been, as general population, watching science fiction movies. And there in 70s and 80s and even 90s, we could see video conferencing and thinking that this is only possible on film. Because our remote communication was based on stationary, old-fashioned telephones, and then in 90s we got some mobile phones, and first in 21st century, primarily within the business meetings, we started using video conferencing, and within last 5-10 years. FaceTime and other video apps became available on our smartphones. So that is actually what we have seen during COVID-19. However, this book that I'm presenting here has been published a few years ago, and it is called E-Mental Health, as Telepsychiatry is just a little part of E-Mental Health. And there you can read a lot of interesting achievements within telepsychiatry and other types of technology that we use in psychiatry. But let's speak about COVID-19 because that is the topic of interest today. When it started once in January, February, we professionals produced a number of articles describing the impact of COVID-19 outbreak. And that impact was, of course, primarily on mentally ill individuals that became worsened, but also on general population, and nevertheless, healthcare professionals. Today, we can predict what will happen after COVID-19 based on our previous experiences with SARS outbreak. So all in all, there is a reason to think forward, and there is a reason to analyze what we have done since COVID-19 outbreak. At that time in Europe, where I live in Denmark, we limited access to care for all non-severely mentally ill patients. So only psychotic patients could enter the emergency ward, while majority of psychiatric patients got offered telephone consultations. They could write emails to us, we could exchange text messages, and in some cases, not majority, in some cases, they could come in contact with professionals by use of FaceTime, WhatsApp, Viber, Skype, Zoom, and so on, well knowing that all those applications are not patient safe. At the same time, we had, and we still do have, some professional softwares that are secure and compatible with standalone systems. When I say standalone system, I mean standalone video cameras that we have been used, that I've been working with for last 20 years, and that equipment is installed in any hospital in Europe. almost every psychiatric department in European Union do have installed video conference equipment. This means that we could easily stay at our psychiatric hospitals during the worst COVID-19 outbreak and social isolation, providing psychiatric consultations to our patients from home. If the patients used life-size, WebEx, or a few other secure softwares that are very easy to install on their mobile devices, laptops, smartphones, and are compatible with our standalone systems. Why we did not choose that opportunity is something that we can discuss somewhere else, some other times. But it was the motivation for me to write few letters, editorial letters and short articles describing the possibilities of home telepsychiatry, advantages and potential limitations. And I sent such letter to WPA that responded immediately. So today we have a little expert group on e-mental health that is aimed to advise national psychiatric societies worldwide in use of technology and how to rapidly set up functional and standardized telepsychiatry services, home telepsychiatry as well as institutions telepsychiatry. So we have different possibilities and perspectives, not only within this COVID-19 period, but also later. What I realized during the previous presentation, maybe I'm wrong, but I think that I perceived the presentation as the rules related to home telepsychiatry exclusively. And home telepsychiatry is something that we have known for, let's say, last 10, 15 years. Only few colleagues in the world provided it by use of Skype, while telepsychiatry that we know since 1959 is primarily based on standalone equipment that has a number of advantages compared to video platforms that are in use while speaking about home telepsychiatry. So we have clinically unsupervised setting, which is the patient location where there is no access to clinical stuff. It means that the patient is sitting at home, which is probably what previous presentations was about. And of course, there are certain limitations. We cannot make somatic examination. We are limited in order to read the body language because we cannot control the video camera on the patient's side. And there is increased risk of the patient recording the sessions and publishing it on the internet. It is very easy. And the last limitation that we cannot predict is electricity power failure and disrupted internet. So that is home telepsychiatry that we could provide on different levels depending on the technology that we do have and the rules that we have or we do not have. On the other hand, institutions telepsychiatry means that the patient is there where there is the access or support from medical staff. What is it we are talking about here? It means that me as a psychiatrist in this very moment, I'm sitting in Stockholm at psychiatric department and my patient could be in Denmark within outpatient ward in Denmark, in Copenhagen, which means that the patient comes to the hospital, meets the nurse who will open the door to the office, and patient will sit in front of the TV and speak with me sitting in Stockholm. It means that we have institutionalized telepsychiatry where there is access to medical staff support to the patient. At such institutions, we do have standalone video equipment that will enable us to remote control the video camera at patient site, and will enable us to read body language and avoid a number of limitations and obstacles, and even misinterpretations that could lead to wrong diagnostic and treatment decisions. However, it is not prohibited to use video platforms and video apps that we use in home telepsychiatry. This video is very short and will demonstrate the use of standalone video equipment. It is recorded back in 2004, and it is me when I was much younger. And you will be able to see the options of zooming in and out, remote controlling the patient's video camera, enabling us to read the body language even better than in person, because in person you cannot come close to the patient 2-3 centimeters to the eyes without being misunderstood. On distance, it is possible. So while speaking about standardized institution telepsychiatry, we actually do have a number of options that we do not have while meeting patients in person. And of course, there is a number of patient populations like autistic patient, child and youth, immigrants and refugees who prefer remote consultations rather than in person of many reasons. However, the technology, COVID-19, and future disasters teach us that it would be wise to combine in-person approaches with telepsychiatry and other technology-based approaches. So it is so-called hybrid model, which is probably the future of our clinical work. What is extremely important is that we incorporate e-mental health, which means the use of telecommunication technologies in psychiatry, as mandatory part of medical education already for students at medical faculties, and of course more detailed during the specialty training in psychiatry. If we teach our students and our young colleagues about advantages but also limitations of technology, then we will achieve a much more and much higher understanding about the possibilities of technologies. Educational initiatives that we would suggest from WPA while making a general world telepsychiatry guidelines that I'm involved in within these days is also that we will suggest to launch competency training courses related to mental health, especially telepsychiatry. However, making the courses mandatory may create issues and obstacles for clinicians to use the technology. But on the other hand, patient care is very important, too important to leave to chance. So my suggestion is that WPA, as well as national psychiatric associations, should offer a process in which clinicians are rewarded for taking initiative for skills and competency trainings. Why? Because of pictures that I will show now, different pictures of how we use video equipment, how we use Skype, how we use Zoom, and how we use telepsychiatry at the end of the story. So we need to learn where is the camera, where we need to look, how the environment should be, how the background should be, what is suitable for telepsychiatric consultation of high standard and what is not. Telepsychiatry should imitate in-person consultations. Video conferencing of high standard should imitate, to a large degree, meeting in person. This means that we need to think about environment, background, and so on, so that the video conferencing feels as natural as possible. That is why our clinical work should also look like it is in person when we do it through telepsychiatry. Once we establish standardized services, once we learn about how to use technology, then we will be able to establish international services. It is something that I did back in 2006. That is the first and still the only telepsychiatry service where I used my colleagues speaking different languages in Sweden to treat patients in Denmark, so that we avoid use of interpreters. My goal was the treatment and assessment of refugees and migrants without use of interpreters. But not only ethnic minorities could be treated by international experts. We could use international expertise in order to teach each other, in order to increase experiences and competencies, as well as to offer second opinion services and so on, in order to increase the quality of care. COVID-19 made us forget the huge crisis that we have had and still do have in European Union, refugee crisis with over 7 million new refugees. Right now we have around 60 million refugees in the world. There are ongoing wars that will never stop, and refugees will keep on coming everywhere. This means that our services need to be changed and adjusted to needs of refugees and migrants as well. It means that the patients from India that I could meet tomorrow in Stockholm and that accidentally do not speak English or Swedish need consultants, therapists that do speak their languages. Otherwise, we need to use interpreters, and using of interpreters in psychiatry is a disaster. That is what I wrote about for many years ago, and this transcultural telepsychiatry means use of cultural competent bilingual therapists that speak the same language and come from the same culture as the patients. That is completely new inventions that I made within telepsychiatry 15 years ago. So whatever we want to change, we need to take active part in changes. If we see that something is not functioning, we need to think out of the box, and it is not easy. But once we focus and realize and are aware of limitations of us as professionals, limitations of the services that we are functioning within, then we are ready for the innovation. COVID-19 is such a perfect timing. However, we may not understand that telepsychiatry is excluding in-person consultations. Telepsychiatry and use of technology in general should be a complemental complemental to existing systems in order to increase quality, in order to offer the best service to our patients. And once we perceive telepsychiatry as incorporated part of the system of mental health, then it will be well accepted by both patients and clinicians. So that is all what I had for today. Thank you for your attention.
Venkatesh, you have to unmute.
Audible?
Yeah, fine, go ahead.
Yeah, thank you very much for a wonderful presentation, sir. So Dr. Dev has very well covered up about the need for training the postgraduates, keeping telepsychiatry training as part of the curriculum, and the kind of technology what we need to use. The need for the hybrid model, like the rightly it is we try to place the telepsychiatry in the right segment where it is not only telepsychiatry, it's not only the face-to-face consult, it is the combination of both. But the need of telepsychiatry is very much in existence right now. I think we can open up the conversation. So yes, actually he touched upon COVID-19. The topic, the idea of telehealth or telepsychiatry in the times in between the COVID-19 crisis, either you can take it, the current day pandemic forcing us to adapt to telehealth and telepsychiatric practices, or the movement of telepsychiatric practices itself in the last 1 to 2 decades with the technological advancements preparing us. Either way, we are in the crossroads. So it is shaping us for the next required tectonic shift as far as the clinician and their expertise, be it the technological, be it the clinical, and the interface the way we need to cater. I have a couple of questions. I think to begin with, are there any specific criteria how to suit who is a better candidate for telepsychiatry?
You're asking the question to me or to Dr.
Yes, sir. Dr. Suresh.
Yeah, it's basically, if you ask me, any first assessment, you can, first time if the patient comes to you, first consult, you can go ahead, do the assessment. And to continue or not to continue is left to you. If you ask me, if the patient has high suicidality, or if there is a personality issues which repeated suicidal attempt is there, legal issues are there, and there is a medical comorbidity which is very high. It may be diabetes, hypertension, and those are the cases I would like to be calling them for in-person. But at this point of time, during the pandemic, I would still go ahead with the telepsychiatry consultation with all the limitations. But once the pandemic comes down to some extent, I would like to call them for in-person. Wherever there is certain patients do not fit for telepsychiatry consultation. Please do remember, there may be legal issues are there. So again, I'll repeat, personality issues, medical comorbidities, which needs that what we call it as the in-person, and also the patients who are highly suicidal and past history of suicidal attempts are there multiple. So, and legal issues, those are the cases I would like to choose for a telepsychiatry, in-person consultation.
Dr. Dev, could you address this question? Is there any particular format for prescribing the medication? Is it has to be digital prescription, or can it be written prescription which is scanned and sent to the patient? Is there any particular format we need to follow?
I find this very interesting because, I'm reading different guidelines from different countries, and I can only refer to our practice in Europe. And maybe because I have never visited your country, I would love to see India, but I don't know how your system is functioning. While we are sitting here and talking, I'm able to log in to a special online system in Denmark and send the prescription to my patient, to patients that I do have. I can, previously I could call the pharmacy by phone and prescribe the medication. So maybe it is completely different way of doing things than in your country. But regarding things that we have heard from Dr. Suresh, and I have heard it many times before, a kind of advice to colleagues that are new in the field. Please do choose the patients that you already know. I understand this cautiousness. I've been doing this for 20 years, and believe it or not, most of my patients I never shake hands with, never. I do not want to say that it is wrong to see patients that we do know from previously. But again, as if we are talking about two different settings, what Dr. Suresh was talking about and what these operational guidelines obviously are about or are referring to is home telepsychiatry, when the patient is sitting at home far away from the hospital and thinking, now I feel bad, let me find the psychiatrist. It is only one little part of telepsychiatry. Why not thinking also that the general practitioner is everywhere? At least in Europe, every little city and village do have general practitioner, but they don't have psychiatrists. So the patients come to general practitioner, who is the doctor. There is a nurse, there is a TV, there is a video camera that could be remote controlled. Connect to Dr. Suresh at psychiatric hospital, and then Dr. Suresh is talking with the patient at general practice, even if the Dr. Suresh did never ever seen the patient before. And there it will be possible to make assessment even of suicidal risks, which I also did. Because we have another colleague, which is not a psychiatrist, but general practitioner, we can advise general practitioner on treatment suggestions, or maybe referral to psychiatric hospital if it is necessary. So, you know, they're always like we are talking about two different levels. Home telepsychiatry is risky, it is necessary, and it is important, and we need it. But we need to know that there is also another part of telepsychiatry that is much more reliable.
I think the question was again that there's a risk of modifying a prescription. So what can be the foolproof safe method where, you know what, you send a prescription where, because these are documents which you need to save from the legal perspective. So what could be the best way to set a prescription which is unmodified? Is there any particular format, what digital format, what we are speaking?
As I mentioned before, I have not seen paper prescription for 20 years. So, you know, nobody can modify anything because it's secure, encrypted system where you just prescribe directly to the pharmacy and that's it. So probably it is something else is happening in your country. I don't know what the system is.
How do you say, sir, Dr. Suresh, you are more in touch with the ground reality. How should a clinician like me, if I have to send a prescription to my client, what should the format, what digital format should I be using?
Yeah, if you sending the prescription, see, the telemedicine practice guidelines, when it was drafted from India, we wanted to reach the rural population.
Yes.
Let's be very clear about this. Yes. India, from the ISRO, we have reached Mars, but not reached our rural population. And this is an unfortunate incident. So, but anyhow, so for the keeping the focus of the rural population, you can send the prescription either by a photo, take a photo, send it, scan it, send it. So it's patient-friendly telemedicine guidelines. Of course, you have a bunch of what we call it as softwares. That should not become a rate limiting factor. See, if you look at the first guideline when it was written, it was hardware heavy, software heavy. They said this is the minimum requirement of applications. This is the minimum requirement of app. It should have this much of zoom lens. There should be the optical zoom. All things were there. Then one of the person who is in ETI clearly said, make a guideline which is patient friendly in the rural population. Imagine your dad is sitting in a rural area. He should connect you. And he should be able to connect any doctor he wants. So that should be. So send any photo, that's fine. So now you asked one question. Can it be misused? Okay, if a person comes, Dr. Venkatesh, to you, you have issued a prescription to him, he can misuse it. No, he can take a printout, he can take a, what we call it as, scan it and send it to many patients, other people, or maybe to the pharmacy. See, misuse can occur in person also, here also. So it's both the same, if you ask me. So, but the telemedicine guideline on the telepsychiatry operational guideline is basically to reach the rural population, where 70% of our population is there. So hope I answered your question, Dr. Venkatesh.
Yes, I think like the practical reality remains the same. It's the way we see, we approach it. I think you just scan it and send it, and the true purpose is to help the patient. I think that should be the primary motto in taking it. I think the next question is this: can you please tell how to stop patients from modifying? Sorry, in case of an emergency, can we prescribe medications for the time being? Suppose, let me deliberate on that. Suppose there's a patient with depression and suicidal ideation refusing inpatient consultation. So can we start an antidepressant?
I would rather refrain doing that. The patient is already suicidal and you are prescribing antidepressant. Imagine if it is imipramine or something, he may overdose it. Because the telemedicine guideline clearly says that if the patient requires emergency care, don't engage them. You have to do a counseling and make sure that they reach the hospital, or else refer them to the hospital, nearest hospital, or a nearest psychiatrist, or even nearest doctor. That is very essential, because that's very clearly written. In emergency situation, you can't do anything sitting far away. So that is the way it has been perceived in the telemedicine guidelines. But however, let me tell you, in anesthesia, okay, if the doctor is on the other side, okay, if like Dr. Venkatesh is on the other end and I'm the anesthetist here, I say, doctor, why don't you do Venkatesh ABCD? It can be done. But if it is doctor to patient, then the limitation starts. Okay. Imagine if there is a, what we call it as, the patient is with somebody else, maybe another healthcare worker, and the patient is suicidal and they are contacted you. The healthcare worker, you're able to identify and you're able to follow the telemedicine guidelines, you can prescribe the medicine to the general physician on the other side, maybe a healthcare worker, why not? So, but please do remember, in-person consultation is required in emergency.
Yes, I think I do understand. I've read this. Like Nimans has been very much into this assisting the primary care physicians, where you try to equip them to deal with it. So the specialist services are always at the background. So the first line is taking the control, but everything is in access. So, but this is a day-to-day challenge. I think this is a scenario, but I think the message taken, it's ideal to refrain when there is a alarming risk, keeping in view the patient's safety. That, the best course of action is to ask him to meet the nearest doctor. One more question, sir. Is yes, telepsychiatry, you very well mentioned that the idea or the intent was to, yes, reach the most rural part of the country and let the service be accessible to all. But again, the technology is available for everyone, even in the urban pockets. So, and the kind of treatment gap what we have in a country like India, it's so enormous. So, public and the private care, there are so many platforms today which are trying to provide telehealth and telepsychiatric services. So, do we have any specific guidelines for these platforms? How? And the question is from the context that who is going to save the data, and patient confidentiality, the legality issues. So, like, what is the guidelines? Because there are so many doctors who are being part of the audience group. I think we would like to address this.
Yeah, this is very interesting question. See, the telemedicine practice guideline do not talk about the data, where the data will be saved, who is going to save the data, whether it will be in the cloud, who is the service provider. But however, if you just take the IT Act, okay, there is something called as in 2011, there is a aggregators, there is a guideline which has been made clearly, what we call it as intermediaries also it has been called. For example, Practo is an intermediary, okay. So there, the data, who is the owner, that has not been decided. But however, by default, it is the patient, if you ask me. Unless the patient gives you the consent to any person, it may be a doctor, it may be a third party, it cannot be misused. And especially in Mental Health Care Act is there, the data is owned by the patient. I'm not talking about the IT Act, I'm talking about the Mental Health Care Act. A. B, is there any guideline for these applications? What should be the minimum standard? There should be any HIPAA compliance. This was again written in the second or third draft. We said we have HIPAA compliance, the NEHA Act came in between, and then Disha came, and now there is a Data Privacy Act bill, which many things came in between the guidelines actually, but they were very clear. If the doctor side, if he's able to maintain a reasonable degree of privacy or security, and if the data breach occurs by third party, suppose you are using a internet, somebody hacks into it, or else the server, somebody hacks into it, or the patient side, somebody does some mischief, the doctor will not be held responsible. So that was very clearly told. Again, the hardware related also was written, but they said nothing doing. Make it as simple as possible. We are now getting mobile phones, which are amazing. At simple 6,000, 7,000 multimedia mobiles are available. So make it very simple. The hardware and software, don't bring hi-fi things. HIPAA compliance was removed. Security, whatever 123, 163 all came. What is that? Bytes encryption should be there. They all removed all those things. They said if the patient is able to consult you over a simple, any platform, please use it. So they did not say that this has to be application. But however, Telemedicine Society of India would like to come up with certain, what we call it as QC, that is a quality control. For example, we recently released e-Manas, that is from the Karnataka state government along with NIMANS. Before we upload into the government server, there is something called as quality control. QC is being done. These are the minimum things has to be there. There should be no bugs, or they should not destroy other data, or else it should not corrupt. There should not be any leakage available. So those QC are being, guidelines will be formed. And I'm part of the group of TSI where we are involved in the security issues or discussion. I hope in shortly we will come up with those guidelines, and these all applications, telemedicine applications will be evaluated on those guidelines, and these can be considered as TSI endorsed applications. Tomorrow it may be not far. Already FDA is approving certain applications from the US. In India, some of the applications are approved by the government, and TSI also may come up with those guidelines, and it's not far that the applications or the operators, what we are using, like telemedicine, can be part of what we call it as endorsing, because doctors are very bad at what we call it as this technology. Many of us, some of them now, new kids who are coming from MBBS, they are brilliant, if you ask me, in Indian. They know OBS, they know how to do streaming, they know YouTube, they are good, but the old timers, they find it very difficult.
I think Dr. Deva wanted to say something.
This here discussions about patient security, safety, documents, and so on. So I've been promoting telepsychiatry for 20 years. And this was the major argument against telepsychiatry that came from our colleagues. Patient safety, patient security, patient safety, patient security. Actually, that was, we were hiding behind the patient security because we did not want to change routines. But nevertheless, patient security suddenly meant nothing when we came into COVID-19 and tried and started to communicate through Viber, WhatsApp, Skype, Zoom. All of them, they have security issues. But technology cannot bridge the gap of user behavior. And most of real technological harm to individuals comes from people using products in technically correct but harmful manner. So, security is one thing, but we can always abuse it. So yes, it is also about the patient and the doctor, how we use the technology. And when it comes to video platforms, I think that we need to think right now, standalone systems are still expensive for personal use. But for general practices, for hospitals, it's not a huge amount of money. And in perspective, we will be able to buy standalone systems and have it at home. That is why we need to think forward so that video apps, video platforms are compatible with standalone systems. That will be wise to develop and to use. so that we have possibility to remote control video camera and read body language and are more sure and reliable in our clinical judgment, diagnosis, assessment, and treatment at the end of the story. So that is the requirements for video platforms from my side as a practical clinician.
I do agree. I think you both have touched upon two aspects of the same dimension, where it's the clinician's attitude for the change, the traditional orthodox practice where everything builds his own routine and the repertoire, the way he wants to function through the day. At the same time, the way that we are responsible for the patient. So we think it's one-sided responsibility. We think, this might not be good, this might not be safe. But at the end of the day, it is inevitable. We have to evolve into the new platforms and new approaches. I think the next question is more from the clinician's perspective. Like Dr. Suresh briefly touched upon this, that there are different rules and different guidelines when it comes to in Karnataka can have different guidelines and Punjab can have different guidelines. India and Canada or Denmark can have different things. Can any of you tell us actually is you have to be registered in those medical councils in different societies at the state or the national level or the different countries. So do we have any uniforming stand or a platform, or does this not, for example, me not having a registration in Andhra Pradesh and there is a client of mine who comes from Andhra Pradesh, can I really see this patient or not? That's it. That was the actually trickiness here.
Okay, Dr. Venkatesh, the telemedicine guidelines which was notified, it's very clear. Within the jurisdiction of India, you can provide consultation to any part of the country, within the country. So that's very clear. But however, some of the states are insisting, like for example, Kerala MCI has issued a notification that you have to provide consultation within the state. But if somebody provides for a Kerala patient, what they will do, that is not there. But however, let me be very clear, as the liberalization goes, it has to be open. And the current government is very clear that they would like to open for international tourism. There are many countries who are ready to tie up with India for providing teleconsultation. Why not? I think we should open our borders. If there's a bilateral agreement between two countries, like Nepal and India, if the doctor's medical degree is recognized in Nepal, why can't we do it? Or else a doctor in Nepal or maybe in Pakistan, there is a doctor on the other side and there is an agreement. Why not? Because I will give an opinion and the doctor sitting in Pakistan issues the prescription. So I think we should be open for this, because already we have to decrease. See, there is a huge mental health gap, especially the treatment gap, especially in these developing countries. And the doctors are very less,
yes,
especially psychiatrists. We have 136 crore population. 136 crore is not small. It's like huge. It is 4 times of US. And we have 1/4 of US psychiatrists. They have 40,000 psychiatrists. We have hardly 8,000 psychiatrists. And in IPS, it is hardly 7,000. And we have to provide a huge, what we call it as the treatment gap is huge. We have to be innovative. We have to use this technology. Let me be very clear. One more point. It's many times it has been misunderstood. The technology cannot replace the shortage of manpower. The technology can only redistribute the urban concentration of doctors. That's very, very important. Because this telemedicine is available, the lack of doctors or psychiatrists cannot replace it. We have to come up with innovations to increase the number of psychiatrists or the mental health professionals, or else training our what we call it as physicians or maybe general medical doctors. We have to, so that we can decrease the treatment gap. Yes, Venkatesh.
Yes, sir. Dr. Dev wanted to question.
We do live and act locally, but we need to think globally.
Yes.
That is why we do have technology. So internationalization of services, expertise exchange, and so on and so. There are a few interesting tips that I do have for my Indian colleague. That is what I remember when I read his guidelines first time for 1 month ago, that only patients from India that are located in India may be treated by doctors that are also located in India. But there is a little trick. We are now meeting in the cloud, okay? So the server where we are meeting should be in India. Legally, the server where we are meeting in the cloud is in India, patient is in New York, and Dr. Suresh is with me in Stockholm. But we are meeting in the cloud legally. I'm not advocate. Dr. Suresh is expert on that level. The other point that I do have, because I've been working within this field for 20 years, and we have had a shortage of resources for 20 years. There is something that we call locum doctors. That is my role right now in Stockholm last 2 months and next 3 weeks. And then I will not probably work for next 3 months doing guidelines and other things for WPA. But we have a number of colleagues. One of them is from Helsinki that I have known from international conferences for 20 years. And he is 77 years old. He's retired. But he comes here as a locum doctor from time to time, working 1 week, 2 weeks. So regarding a shortage of resources, by use of technology, we will be able to reach our colleagues that retired for some years ago, but that are still not dead, that are still able to provide consultations and services, not on full time, not by traveling for 1,000 kilometers, but from privacy of their own homes. It will not change dramatically the shortage of resources, but it will provide a number of psychiatrists extra that are now sitting at home and, are still, functional.
Well, I think for India, for sure, the psychiatrists are not extra. Actually, we are extremely short in this case here. We are completely overworked. And I understand the sentiment when Dr. Suresh mentioned that we need to have bigger numbers because quality is very much essential, especially in our line of work in psychiatry. I had two technical questions, brief ones. Who should place the call? Can a doctor place a call? Or does it become not informed consent? Because when you mentioned patient contacting the doctor, can it the other way around can be seen as lack of consent?
I could not get you, Venkatesh, the question.
If I place a call to my patient,
Okay.
can that be seen as no consent, but I am the one who is initiating a conversation? Is it mandatory, or is it okay that anybody can place a call for a video consult between the patient and the doctor? Because effectively speaking, a patient walking into a chamber, it was always seen as an informed consent. The patient is visiting you.
Okay.
Yeah. So is there a necessity that we should ask the patient to place the call so that it can be seen as a consult, or does it hold any legal ground?
See, if you look at our telemedicine practice guideline, it is very clear. Legally, the patient will initiate the consultation.
Yes.
So it is considered as implied consent, is equal to walking to your chamber. But if you want to contact, that's the issue you're raising. Okay. Yes. If you want to contact, if he is your old patient, no problem at all. You can clarify, because the telemedicine practice guideline says you can choose, like suppose the patient has contacted over email, you can do the video consultation. It is, you can choose it is the professional judgment of the psychiatrist to choose the mode of consultation. It can be text, it can be audio, it can be video. So you can choose, but the first initiation has to be from the psychiatrist or the doctor. But however, the healthcare professional, maybe a nurse, maybe a healthcare worker, or a social worker or a psychologist can initiate a consultation, but provided they have to take the consent, and they should be next to the patient. So that's the way it is written like that.
Just a follow-up. Is there a difference between a video-based consult and a chat-based consult? And can a prescription be given by a chat-based consult? The reason being, there are a good number of platforms which are providing chat-based consultations, but the real challenge comes in wherein it is not surprising the psychiatric patients, they prefer to be anonymous. they would take profile as a user or as an anonymous patient, and the question comes in with collecting the social demographic data. But good number of practitioners, because the patient presumes that the consult will be followed by such prescription. Do we equate the chat based and video based consult, or is there any difference?
Okay, Venkatesh, again, the same thing. The telemedicine practice guidelines by the ministry which has been released, it recognizes all three: text, audio, video. All three have been recognized. For text, okay, first consultation, if they are doing first consult, text, only over-the-counter medication can be given. But if the first consult is video consultation, you can give list A. With video consultation, only list A can be given. Once this is about the first consult, text, audio, only list O. List A, it has to be video consultation. Now the patient is coming to me every day, or sorry, every month for in-person consultation. Okay.
Yes.
Now he sends me a message. I have a side effect. I can send him a message telling take triaxiphenidil 2 mg.
Yes.
So that is allowed. Chat. That is list B is allowed if it is a follow-up.
Okay.
Tele follow-up, list B is allowed. So let's be very clear about that. List B, tele follow is allowed.
Okay. There's one more question. Can we prescribe homeopathic medications by teleconsultation?
Homeopathy, please don't do cross, what we call it as a cross medicine consultation. Please don't do. It will be considered as a, if you look at the MCI 2002 practice guideline, they have clearly prohibited. Allopathy doctors cannot prescribe homeopathy or Ayurveda medicines. If something goes wrong, you will be held responsible. Nothing goes wrong, so nobody is bothered. You can say, sir, homeopathy medicine hai, kuch nahi hoga, nothing will happen. But the guideline is very clear. You are not supposed to prescribe homeopathy or other system practice, Unani, Ayurveda. You are not supposed to do that.
So if the patient does not follow up, but we know he requires follow up as there are few risk issues, can we do a assertive follow up with the patient?
Sorry, I could not get the question. Please be louder.
If it is your own patient and you know that your patient is at risk, there might be some side effects, medications, or anything. So can we outreach the patient? Can we do an assertive follow-up from the doctor's end?
Yes, why not? See, for example, I can give you, Venkatesh, if the patient comes to me and is a chronic schizophrenia patient, you can take a consent that I would like to, send a message or call you after 1 month. And if he gives consent, why not? Like e-Manas, what I'm talking about, the application portal which has been released by Karnataka state government. If the person is getting, it's a government portal which has been given free of cost to doctors and also to the psychiatrists, private and public both. In that portal, when the patient is getting registered, the question will be asked, can the government can contact you? Suppose the patient is schizophrenia or some severe mental disorder, and if it does not come for follow-up, 1 month down the line, the message goes, if he has given consent. And if he doesn't come back, 2nd month, the message goes. If it doesn't come back, 3rd month, the DMHP team goes to his house. So that's the way it is. So
yes, I think you have rightly addressed the question. I think we have covered a good number of things. I think I would ask Dr. David to give any closing comments for the. I think he touched upon the COVID-19. So, how do you see what could be the key issues which we need to focus on? A couple of closing comments on telepsychiatry and the mental services.
I used to say better late than never. I've been promoting telepsychiatry for 20 years and better late than never. Unfortunately, COVID-19 is not a nice event, but it opened our eyes for limitations of the systems that we are functioning within. And that was obviously necessary in order to start using technology that we have known for decades. And now the future of e-mental health, inclusive telepsychiatry is very bright. It requires few things that I have already mentioned. It requires education, introduction, training in competencies, and the use of common sense. E-mental health is a way of thinking. It is not just solely use of technology. So we need to change the software that we have in our heads to think in terms of remote consultations. And it is good that we have guidelines, but using common sense will lead us much further. So, you know, I think that we should primarily be pragmatical rather than to be limited by rules. And that is why I am looking forward to finalize the guidelines that the WPA will distribute and recommend, so that we have global guidelines that could be adjusted to local needs. And that is the base for international collaboration, which is still my dream.
Thank you very much, sir. Thank you for your inputs. Dr. Suresh, any final closing comments, sir?
I would rather say, please use telepsychiatry guidelines to reach your patients as much as possible. And this pandemic is going to cause a lot of what we call it as mental health issues in the near coming days. And we are seeing suicide rates are increasing slowly. I think we have to be proactive, use telepsychiatry as much as possible, and reach our patients. Thank you for the opportunity.
Well, actually, we are at the concluding part of the conversation. I would say the key takeaways from the entire intense discussion which we had with the eminent speakers is, yes, telepsychiatry should be part of the repertoire. I think it is more from the clinician's perspective, the barriers there, you know, it is our mental barriers, you know. The clinician should have an open attitude towards adapting to the changes, because yes, many of us, we are not trained in telepsychiatry as part of our undergraduate or postgraduate curriculum, which will be probably knocking on the doors of the young doctors, where it should be part of the curriculum or the CME programs. But we should be open enough, because the advantages are immense. The mental health is available for all. It can reach any part of the country. Your patient is safe at the end of the day, which is the primary motto of every doctor. It is far wide-reaching, and there is a better compliance. And alarmingly, the patients are immensely satisfactory and acceptable when it comes to telepsychiatry. I think we see this as a very good change, and clinicians can serve as a gatekeepers, and you know, we can incorporate and make it as part of a repertoire. I thank once again Dr. Deva from giving a wonderful talk at such a short notice. And yes, we all know in Indian Psychiatric Society, such as Dr. Suresh and his contribution towards telepsychiatry, it's been immense. We keep looking forward to you, sir. And thank you for doing this platform this time. And to conclude, I also thank Practo for organizing this event. The kind of treatment gap what we have in a country like ours, as far as especially with the mental health, it is not just the public involvement. There is a huge amount of potential for the private healthcare to be part of it, because yes, we are 135. It's not a country; it's a continent, and there are so many people, and we are so few in hands. So we have to come in together to make sure that the mental, emotional, and health, overall health is very expensive. Thank you, one and all.
Yeah. Bye.